Alright, hello, my name's Antoine. Everyone's staring. Alright, let's get started. So, my presentation will focus on some of the graduate research that I did and conducted in late 2015 on right to die advocates in Belgium. So, predominantly caregiver-patient advocates with a variety of healthcare professions. However, before I discuss approaches to assisted death that could potentially be applied to suicide prevention, I'm going to give a little overview of the Belgian case. So, as of 2002, Belgium legalized the use of assisted death, or euthanasia as is used there, and it doesn't have the same negative connotation as here, for cases of unbearable suffering. So aside from other countries that, let's say, Netherlands and Luxembourg, countries that have assisted death will predominantly focus on terminally ill, whereas Belgium does not. Its unbearable suffering is the key. So the category can encompass physical, psychiatric, and existential suffering. So although there is no agreed upon definition of what unbearable suffering is, at its sort of core, it can be referred to as a degree or condition that is so extreme that it is no longer tolerable for the individual. So the advocate's perspective. So like most other movements, there's rarely a completely unified voice that encapsulates all of its members, and the Belgian Right to Die movement is no different. It's fractioned, and there's subgroups with different views and values according to how this should be done. However, through conducting interviews and spending time with numerous Right to Die advocates, I was able to establish a few core beliefs that I believe the vast majority of Right to Die advocates believe in Belgium and internationally. So, one is that suffering can strip away the meaning that people derive from their lives. To quote one of my participants, a Jesuit priest and palliative care physician, and I quote, "One of the most malignant traits of suffering is that it has the capacity to separate us, separate people from the things they love most." All Right to Die advocates I met with fundamentally believe this, that a certain suffering could take away an individual's purpose in life. Another one being that not all suffering can be eased through current medical or other forms of treatment. Thus, it would be unethical to require someone to live in hope of a future or experimental treatment. This was something that was very much believed by the majority of the people I met. Furthermore, that unbearable suffering is considered in relation to whether or not it is temporary or permanent, since irreversibility eliminates hope. And the last one being that assisted death is distinguished from suicide. And to quote another one of my participants, a psychiatrist who founded the Wankel, which is a euthanasia clinic. And she says, "Euthanasia allows to keep suffering from silence, and to discuss whether dying is a good solution with the patient and their family. With suicide, it is totally different, since you do it in the corner without speaking about it. So, and which is often an undignified way for a human to die." So, advocates uniformly argue that assisted death can provide a sense of closure and understanding to those deciding to end their life, while suicide leaves those with questions, with those close to them with questions and multi-generational trauma. So, death talk. The euthanasia question was basically described to me as the last lines of any pharmaceutical advertisement, being, ask your doctor today if assisted death is right for you, which I found was interesting. And it is in these patients' initial inquiry on whether or not medically, they qualify for medically assisted death, that it also opens up the door for the first step to discussing their wish to die with a professional and others. So this indirectly creates a space for patients to discuss their wish to escape suffering through ending their life. That will not immediately be imposed by solutions of institutionalization or professional dismissal. So in terms of the dialogue as there, so Dr. Liev Thinkman, which was one of my participants and a psychiatrist who founded the euthanasia clinic in Ghent, called the Wankel and practices psychodynamic therapy with patients who have euthanasia questions, explained to me that People think that if you talk about euthanasia, it will bring ideas of euthanasia. But they do not realize that those people are constantly thinking of death. It is the contrary if you talk about euthanasia. They can stop totally being focused on suicide. So, in other words, she believes that silence around around thoughts of ending one's life and stigma attached to such thoughts pushes it past the margins of social acceptability. Another participant, a retired professor of medicine and doctor, and who by many is considered the father of Belgian euthanasia, echoed this sentiment, adding that for some patients, the knowledge that they will be granted access to safe, assisted death keeps them going. To live on, knowing that after being approved for assisted death and keeping it as an option if things were to deteriorate. And Dr. Fink, who I referenced earlier, further elaborates that to discuss euthanasia allows for some of the patients to decide not to do it. More than half the patients sometimes, because we will advise them on other tests or treatments. She provides the example of Marjorie, a patient who came to her with a euthanasia question, since her doctors had told her she had psychotic episodes, and the medications that she was provided were simply not working. When she came to the clinic, it was clear to the psychiatrist that she had been misdiagnosed and in fact had a form of autism. So since that time, it had been a few years at the point of our interview, and this individual, Marjorie, was very much still alive. So this article, which looks at 100 requests for euthanasia and then the outcomes, specifically for psychiatric disorders, was spearheaded by this psychiatrist that I keep referring to. And the results I find pretty interesting. So looking at 100 people, you have 55 who were referred to counseling by their physician, 90 who had one or more disorders, and 58 who had been sort of labeled as depression, and then 50 with personality disorders, 12 received an Asperger's syndrome diagnosis, autism, and 48 requests were accepted, and 35 were carried out. And then out of the 13, a year later, 43 had died of various results. So this is interesting in breaking down, because it's not something that we can typically do here. But more so, the conclusions I find interesting, because the findings depression and personality disorder are the most common diagnosis in psychiatric patients who are requesting euthanasia, which may not be news, but it gives that ability. And what I find even more interesting is the remaining 57 who were still alive 1 year later, with 48 requests on hold because they were managing with regular or occasional therapy. So basically they had gone in with the request, but throughout this process had decided that they were no longer interested. So I think what might be interesting is also, it's difficult to replicate this sort of study here due to the differences in the laws, but there are some takeaways that I think might be useful. This clinic has caught multiple misdiagnosed individuals, as well as supported patients with their families who were not given the proper follow-up by their doctors. It also created an environment where it is acceptable to discuss one's deaths, to be listened to in earnest, and have support in revealing to one's family members hidden struggles. After all, the name of the clinic, the Wankel, in Dutch translates to listening house directly. So I want to end with a story of another participant. His name is Pierre, who is the father of a young woman who died of suicide in a psychiatric institution, and who for years had pleaded for assisted death. After her death, he became incredibly outspoken as an advocate for the acceptance of assisted death in cases of psychiatric suffering. He told me that he had once spoken to a psychiatrist about listening to patients' experiences, and the psychiatrist had responded, "Monsieur, if only you knew all that patients told me. They are sick and should not be listened to." This incredibly disturbed Pierre, particularly because he thought that could these sort of attitudes have had any sort of impact in the way that his daughter had died, and had felt forced to take her life. He later told me that going to the Wankel clinic was the first time he had felt that his suffering, as a grieving father of a daughter who had died by suicide, was truly listened to. Thank you.